Hello, welcome everyone to this ISPCAN webinar. My name is Gabi Otterman. I'm one of three speakers who are hosting you today, and I'll be introducing us shortly. We're delighted to have you with us today as we explore key challenges and updates in child maltreatment coding in the healthcare sector. This session is part of ISPCAN's ongoing commitment to expertise, research, impact, and action in the field of child protection. We appreciate your time and engagement, and we look forward to a great discussion. I'd like to take a brief moment to highlight some key events ISPCAN has planned for 2025. The ISPCAN Huddle every Thursday in May 2025 is an online forum that examines it's a deep dive into a child sexual abuse case, fostering multidisciplinary collaboration and trauma-informed approaches to improve global practices. In July, we will mark the World Day for Child Protection Professionals on the 7th, a day dedicated to recognizing and celebrating the critical work being done in this field globally. In October, we have the ISPCAN 2025 Congress taking place from October 6th to 9th in Vilnius, Lithuania, which will bring together experts from around the world, followed directly by the Rise Up Policy Forum in Vilnius, focused on advancing policy solutions for child protection. So please make note of these events in your agendas. Before we begin, let me share a few tips to help you make the most of today's session. First, we encourage you to engage with us through the chat feature. Please introduce yourself and feel free to share your name, discipline, and country, and to add your thoughts or comments throughout the session. For questions, please use the Q&A features so our team can address them during the discussion that will follow our presentation. You should have about half an hour scheduled for that. You can enable closed captioning by selecting captions from your Zoom control bar under the More options. Finally, after the webinar, you'll receive follow-up materials, including links to the recording, presentation slides, and relevant resources. So we imagine that many of you are familiar with the International Classification of Diseases, ICD. As a reminder, it's the global standard for coding health conditions developed by the World Health Organization. ICD-11, the newest version, is a significant update from ICD-10, designed to better reflect modern healthcare needs. Andreas is going to start us out by presenting some of the results from the Training to Improve Child Abuse and Neglect Diagnostic and Administrative Coding, or TICANDAC project. TICANDAC has focused on identifying barriers to accurate child maltreatment documentation and enhancing healthcare professionals' capacity to recognize, code, and report cases effectively. We see the upcoming transition to ICD-11 as a window of opportunity. While ICD-11 in itself will not solve the challenges of child maltreatment coding, its implementation provides a critical moment to train healthcare professionals and refine documentation practices. So this transition matters for clinical practice, research, and policy. So we have some key learning objectives for today. First, we aim to increase awareness of the need to better document child maltreatment. Accurate and standardized documentation is essential for improving clinical care, research, and policy responses. We will also report on what our research has revealed about common barriers to documenting child maltreatment and discuss some strategies to address these challenges. Next, we will provide a sneak peek, if you will, for what coding child maltreatment in ICD-11 may look like. Unlike ICD-10, ICD-11 provides a more structured way to capture maltreatment cases, which may enhance data accuracy and usability. Finally, we will learn how to apply the general structure of ICD-11 codes. This will include an overview of the coding system with examples of 2 case vignettes and insights on how ICD-11 may support better child maltreatment documentation. So I'd like to briefly introduce the team of 3 today. The full biosketches are available to review at the ISCAN website. Andreas Jude is a full professor of child maltreatment epidemiology at the University of Ulm in Germany and serves on the ISCAN Distinguished Advisory Council. His research focuses on child protection services and improving data collection. He leads the EuroCan Cost Action Project, a pan-European network coordinating child maltreatment data efforts across 36 countries. Myself, I'm a child abuse pediatrician at Uppsala University Children's Hospital in Sweden and an adjunct senior lecturer at the Barnafrid National Center on Violence Against Children at Linköping University. Also serve as a board member of ISPCAN and vice chair of the EuroCan network with Andreas. Amber Davidson is a coding and classification expert with over 30 years of experience in health information and data analytics. As a subject matter expert with the Children's Hospital Association out of Kansas City in the United States, she specializes in ICD coding systems and helps maintain the Pediatric Health Information System database, supporting hospitals with coding-related research and compliance. I'll now hand it over to Andreas.
And I'm trying to take control, and hello to everyone. I've read about familiar colleagues, some who have supported the project, which is greatly appreciated. Now control is with me, and I'm starting to introduce the project. So the first statement about underreporting of child maltreatment in ICD-10 in hospitals is likely rather an understatement, as often there's empirical evidence on rather dire underreporting of child maltreatment in ICD-10, frequently and significantly underreported. So that was a rationale for proposing to European Union's Daphne program project called TIG. Gabby already introduced the title of this project, the Training to Improve Child Abuse and Neglect Diagnostic and Administrative Coding. And we said like it's an excellent window of opportunity to start with improving administrative data collection in hospital care on child maltreatment now that ICD-11 is going to be introduced. And so we're aiming at contributing to the prevention of all forms of violence against children and kind of providing the system with a rudder to steer to better understand which children appear or get recognized in the system with child maltreatment or not. And I've shown you here the link to one of the products of this project. This is an e-learning tool that we've developed both in German and in Swedish, which were the 2 Pathfinder countries. The link will lead you to the landing page, which is also available in English, and we're aiming at trying to have it also translated, the e-learning program, to other languages, particularly English, to make it to scale it up. And here you have, that's a glimpse on the landing page in English, and you see the whole team that was involved in developing, or the project leaders involved in developing the e-learning tool. That was one part, the e-learning tool. The other part was, before developing the e-learning tool, we wanted to better understand why we had serious undercoding of child maltreatment in hospitals. So we did qualitative interviews with child psychiatrists, pediatricians, pediatric surgeons, medical documenters, other administrative staff, child protection coordinators, and several other subdisciplines to better understand that. And this was in total 28 semi-structured interviews with diversity in, as I said, subdisciplines, and also gender, urban, rural, location. And this was just an overview on the themes that emerged in coding. It goes from this systemic parts, so systemic frameworks at the national level, to the organization, down to interpersonal dynamics, cooperation, communication, and arrives at intrapersonal barriers, so the issues with knowledge, competence, and emotional burden. And I'll now go through the different parts, the different categories, to give you an impression of a few of these obstacles to reliably code child maltreatment in ICD-10. So the first part, the systemic part at the national level, was the problem of the professionals, medical healthcare professionals that had to code or should code child maltreatment, that they had to often have to use parallel systems of coding. So systems of diagnostic coding, systems of procedural coding. Sometimes the child protection units have registers on their own. The clinic does have a register on their own, etc., etc. Some, like often two parallel coding systems, sometimes even more. And then there's obviously the legal regulations and conditions that apply. One specific example in Germany is that there were historically problems in coding diagnosis of child maltreatment, because the health insurance did take action on the person responsible for the medical condition of the child, which is the perpetrator of child maltreatment. That often is in a family, so they did take action on the family to get the money back, which did get extra strain on the family on top of the child maltreatment. This is not the case anymore since a few years ago, but this legal condition still impacts coding to date. And there's also the question of, well, being just an example, but in Sweden we had other legal issues. But on top of the legal issues, we also had the availability or often the non-availability of standardized rules, lack of training, education, often like medical health professionals get, if they're not specialized medical documenters, they get a glimpse on the coding while there are students, but not a full training, particularly not a full training when it comes to the codes that cover child maltreatment and other health issues. So the and one important aspect at the national level or the framework level is also that not every code that is connected to a diagnosis is reimbursed, which is true for child maltreatment codes that, at least in the two countries that we did look at, the T74 codes on child maltreatment were not reimbursed, which is it's a qualitative interview, so I'm hesitating to say that this has some representative, or it's not representative, but it seems to be a major or even the major obstacles that we've identified. So advancing one level to the role of the organizational, it jumped down too much, the role of the organizational culture and structure. The problem is often like that, even within one clinic, there were differences in who had actually to code. Sometimes the medical documenters, for the surgical department, it was the surgeons themselves who had to code it. So within one clinic, it might change from department to department, connected or associated with a lack of transparency in the responsibilities. Well, we have here as a next bullet point shortcomings in quality control. This is maybe also a bit understatement. You could sometimes also label it total lack of quality control. There's just coding, no control, whatever is coded or not. Like, often the people some interviewees motivated to document child maltreatment were reporting of a culture and attitude of the clinic that said, oh, you shouldn't do this. This is bad reputation for the clinic if you do child maltreatment coding. It's not nice to do that. Oh, well, maybe not as openly communicated, but the general attitude in informal communication. I'll advance yet another level to the interpersonal dynamics. So this is if they're like having difficulties, should I actually report or document it? Because if I document it, I should report it to Child Protective Services because I have a legal mandate, or at least in Sweden, that's the mandatory reporting to. So that's the question. So these questions in the interpersonal dynamics, hesitancy to communicate the documentation with the caregivers and the child itself. So the felt need to better substantiate it, but then the problem with internal hospital communication to substantiate it with colleagues. But then at the lowest, if you want, lowest level, personal lowest level. There were barriers in the professional itself having to do with a lack of knowledge of coding child maltreatment in ICD-10, even if it's quite simple. We've also asked the people if they're familiar with ICD-11, and like the result is the only thing they knew that ICD-11 exists. And that's, at the time, this is about a year ago, that was about it. And so we felt this directly connects with the sneak peek we're offering. So this felt like an option to introduce you folks who are listening with a sneak peek into how ICD-11 works in general, which is much different from ICD-10, and how specifically the coding of child maltreatment works in ICD-11. There was an uncertainty in identifying child maltreatment. Specifically, if it was apart from physical abuse, health professionals were more comfortable identifying physical abuse, but everything that other forms, other types, there were high uncertainties in identifying them, being hesitant to label it, even if they were quite sure that it's possible child maltreatment. They were still shying away from doing it, and also the other psychosocial factors in influencing the professional's decision making, not wanting, for example, not wanting to blame the parents if connected with their uncertainty in identifying child maltreatment. So this is just a short overview on major obstacles we've identified in these interviews. We have written up an article and submitted to one of the journals in the field, and if it gets accepted, we're happy to also include it in the references when we share it on ISPCAN, and you might be interested to read more about it. But this is my part of the overview, and with the next slides, I'm turning back to Gabby Otherman, and in combination with Amber Davidson, who will give you the sneak peek into ICD-11, and I'll be in the background trying to already respond to your questions or setting them apart. So you see you have the chat button more to the left and the Q&A button more in the middle.
Thanks, Andreas. Yes, this was part of the collaboration between Barnafrid National Center in Sweden and Ulm University in Germany. And just as a disclaimer, we just had to teach ourselves about ICD-11 as early adopters in this field. A few characteristics of the ICD-11 that we've learned. Why is there an ICD-11? Well, the World Health Organization developed it to meet the needs of modern healthcare. Unlike ICD-10, which was designed for paper records decades ago, ICD-11 is digital first, making it more efficient for electronic health systems. One major advantage is that ICD-11 reduces the need for country-specific clinical modifications. This means more standardized coding, improving consistency across healthcare systems. The goal is better accuracy and clinical relevance, ensuring that diagnoses are recorded with greater detail. This is especially important in sensitive areas like child maltreatment, where precise documentation supports better care and policy decisions. While ICD-11 is not itself a major advancement in child maltreatment coding, it provides, again, a critical opportunity to examine and explore improved training and implementation. By making the most of this transition, we see that we can strengthen multisectoral responses for children. So, accurate data on child maltreatment is crucial for healthcare research and policy decisions, and I'm probably preaching to the choir here. Without reliable coding, we risk underreporting or misclassifying cases, which affects services and our ability to develop evidence-based interventions. And as Andreas pointed out, we're way underwater when it comes to underreporting of child maltreatment. So ICD-11 does seem to offer clearer coding categories for abuse and neglect, and may help health professionals document cases more consistently. This is a step toward more standardized reporting and better data for child protection efforts. Another key improvement is the ability to capture more details. ICD-11 allows coding of injuries, perpetrators, and circumstances with a greater specificity. This means that we can provide a more complete picture of the child's situation, leading to more appropriate responses and care. I'm going to hand it over to Amber here.
Hello, everyone. ICD-11 is really a structured, flexible, and layered classification with a new feature for selecting codes. The main structure uses STEM codes, which are the core codes to capture all types of diagnoses and conditions. The new concept in ICD-11 is what is known as post-coordination. Post-coordination allows users to link multiple codes to provide more detailed information about a clinical condition, i.e. that STEM code, that core code. In ICD-10, additional details of a condition would have separate codes reported, but would not necessarily be linked to the code they are meant to explain or provide details for. Thereby, it wasn't quite as clear in ICD-10 what those details might be, what part they're considering, or what injury or condition they are for. In ICD-11, post-coordination allows for the details of a condition to be added and linked to the STEM code to create what is known as a cluster code. Post-coordination allows users to code clinical concepts to their highest level of specificity without having a list of additional codes that are not linked to each other. This modular approach makes coding more comprehensive and clinically meaningful. Child maltreatment cases are often multifaceted, requiring a coding system that reflects that reality and can provide the multiple concepts and information provided in the documentation of a maltreatment case. ICD-11 allows clinicians to code both the injury and its context, such as the cause, the perpetrator, and other details within a single coding structure, i.e. that cluster code. Instead of codes that do not provide a level of detail or codes that are not linked to each other, like in ICD-10, cluster codes create a complete picture of the child's case in one long string of data. ICD-11 provides dedicated codes for the many concepts of maltreatment. These include codes for physical, sexual, and psychological abuse, neglect, exposure to intimate partner violence, and the fictitious disorder imposed on another. ICD-11 also includes codes for suspected maltreatment, and personal history of maltreatment. By using post-coordination, the additional details of a case, such as the location of the abuse, the perpetrator, the location and severity of the injuries, can now be linked with a string of extension codes to create a cluster code telling the complete story of the patient. As you can imagine, with the use of post-coordination, ICD-11 will allow for more precise coding of a clinician's detailed documentation of a maltreatment case. For example, a fracture due to physical abuse can now be coded as a single structured entity, i.e. that cluster code, instead of separate stacked and unlinked codes that may not tell the complete picture of the case. ICD-11 will improve the clinical accuracy of maltreatment coding and will streamline data retrieval for healthcare and research purposes in the future.
So in practice, ICD-11 introduces more clinically relevant coding, supporting better patient care, while also enhancing child protection efforts. With more precise documentation, healthcare providers can better identify and respond to child maltreatment cases. A key advantage of ICD-11 is its intuitive design for digital health systems. It can be integrated directly into the electronic health record or used as a standalone tool for code selection, making it more accessible and user-friendly. Standardized coding is, of course, the holy grail in our field. When coding is consistent, it leads to better data collection, stronger policy decisions, and perhaps ultimately better outcomes for children. ICD-11 may move us closer to that goal by ensuring greater reliability across healthcare settings and countries.
Available on the WHO ICD-11 website, you will find the two components of ICD-11. The first one is called ICD-11 for Mortality and Morbidity Statistics, also known as the MMS. This is the complete ICD-11 classification, and this looks like what you would see in a coding manual or a coding book if you're familiar with those. There are separate chapters, like in ICD-10. You'll find chapters for different body systems or similar disorders and services captured together in that chapter format. For example, there's things for some chapters like diseases of the nervous system, neoplasms, developmental anomalies, injuries, and also external causes of morbidity and mortality. The other component of ICD-11 on the WHO's website is the ICD-11 coding tool. This tool is really just a search engine to use to find your diagnoses and conditions, those STEM codes, as well as to find your extension codes to build a complete code, that code cluster, without having to look through every chapter of the MMS to find what codes and conditions you're looking for. In this view, I show on the left what is known as the MMS, the ICD-11 for Mortality and Morbidity Statistics. You can see it's classified with those different chapters. Here it just shows 1 through 8, and then I go into diseases of the nervous system and look at multiple sclerosis. And as you can see, there's a hierarchy there, where as you look at one condition, you can go further into that to find the actual relevant codes and the detail involved with those codes. On the right, you'll see the coding tool, which is that, get this out of the way there, the coding tool, which is that search engine. So here I have entered in multiple sclerosis, and as you can see on the right side of that screen, there's all these destination entities that pull up based upon the search for multiple sclerosis. And then you would look through those items there to see what is the choice that you would want to make.
So now Amber and I will walk through 2 case vignettes to see how the ICD-11 works in real-world scenarios. These cases will illustrate how the system allows for more detailed and structured documentation improving the accuracy and consistency of coding. Each vignette will demonstrate how ICD-11 creates a code cluster that Amber was describing, capturing key details such as the type of maltreatment, associated injuries, and relevant circumstances. Amber will also show you how she uses the ICD-11 coding tool to show how these cases are coded step by step. This hands-on approach will help clarify how clinicians and coders can apply ICD-11 in practice. A quick suggestion that came from Amber: if you're going to work with coding regularly, it's helpful to get some familiarity with the ICD-11 coding tool, which is available. We will link to again at the end, and the morbidity and mortality statistics, MMS functions. Knowing the right search terms makes finding codes faster and more efficient. Our first case, we have a 3-month-old infant boy admitted to the pediatric ward for evaluation of suspected abuse. The history provided includes an admission by the mother's boyfriend that he had violently grabbed and shook the infant. On evaluation, we see some injuries concerning for inflicted trauma, a left posterior 6th rib fracture, and bilateral classic metaphyseal lesions, or CMLs, of the distal tibia and fibula. CMLs, also known as bucket handle or corner fractures, are highly specific for non-accidental trauma in infants. You may not be aware of this, but like posterior rib fractures in this context, they're strongly associated with inflicted injury. The radiographic image here shows a CML, classic metaphyseal lesion, in the distal tibia in an infant with the characteristic appearance. This injury is, again, rarely seen in accidental trauma in infants, and its presence should raise immediate concern. So now Amber will show how this is coded in both ICD-10 and ICD-11 for comparison.
So in this view, you can see from the WHO's 2019 ICD-10 codes, the various codes that were selected for this vignette. We have the physical abuse, we have the fracture of the rib, but we do not have that it's left, that it's posterior, that it's the 6th rib. We don't have that detail in ICD-10. Again, we have the 2 bilateral fractures of the tibia. We have to use that same code twice if that is allowed by your coding guidelines, as well as the fracture of the fibula, which is just other part of lower leg, again, not very specific. That code is, again, assigned twice if that is allowed by your coding guidelines in your nation. And then we just have another specified person as the perpetrator. So we don't have a lot of specificity here in 10 at all, but we do have that in our documentation. The video is now going to start. I'm not sure, Gabby, if you need to set something. There we go.
I'm now going to use the ICD-11 coding tool for vignette number 1. Here we have an infant with a 6th left rib posterior fracture and bilateral tib-fib, metaphyseal fractures, and we have confirmation of abuse by the mother's boyfriend. So we have a lot of detail here that we want to capture in our code. First, I will type in fracture, rib, and below will appear all the different destination entities that are pulling up based upon our search criteria. So fracture rib pulled up multiple different variations. So we'll just have to review the list and scroll through to see what is our best choice. And here's one for fracture of rib. posterior or posterior and lateral, and that's what we want. We know this is a posterior sixth rib fracture. So I'm going to select the details to pull up the post-coordination options to provide more detail to our code. So select that plus sign. So the first post-coordination option is laterality, which we know this is on the left, so I'm going to select that. Then we have an option for fracture subtype, which if I knew that, I could select, which I don't have that detail. Maybe it's in a radiology report, but it's not in the documentation I have at this point. So I'm going to go bypass that option. Now I do know this is a closed fracture, so I'm going to pick that. Next option is specific anatomy. So I'm going to look at the different choices we have here. And we know that this was of the sixth rib, so we're going to select that option to provide that level of detail. The next option is associated with. This is where you associate the injury with what kind of causation it was. Was it self-harm, assault, maltreatment? And so maltreatment is where the abuse codes are fitting into the ICD-11. So we know this was physical maltreatment, so I'm going to select that. Now we did have some other details in our scenario, such as the perpetrator, information about who that perpetrator was, because this was confirmed abuse. So I'm going to type in perpetrator here. And that brings up some different options here for gender of the perpetrator and the perpetrator-victim relationship, which I want to show that was the boyfriend of the mother of the baby. So pick that, and we know that it was a male. So we've picked all our choices. So we see up here at the top, as we were going through those different post-coordination options, it was building our code cluster. So our STEM code is this fracture code. Also another STEM code is the maltreatment code. And all these ones that start with an X are extension codes, and they provide greater detail to the code instead of having to create a separate code in ICD-11 for every type, left, right, bilateral type of rib fracture that we can have. So I would go over here and select that code, and it brings that up here into the coding tool. Right now, this is not attached to any other software system or billing system, so I'd have to document this off here in another paper or something if I wanted to capture that code. And now I'm going to show you, going into the coding tool, how to code the other fractures that we have. I'm going to start with tibia. We know we have a fracture of the lower end of the tibia, so I'm going to select this post-coordination option here, fracture of lower end of tibia. Here we get all the different options here, which I'm going to just keep with lower end of the tibia right now. We know this is a bilateral tibia fracture, so I'm going to select bilateral. And we know it's metaphyseal, and we don't have a choice for metaphyseal, but we do know that metaphyseal is the same thing as a bucket handle or corner fracture, so I'm going to select that. We know that it's closed, so I'm going to select that again. If I know the joint involvement of the fracture, I can select a post-coordination extension. I'm not going to use the ICD-11 coding tool for vignette number 1. Here we have an infant with a 6. Last code for this patient is code of the fibula fracture. So I looked down my choices. We have some fractures of lower leg, including ankle, but I don't know that. So I'm just going to pick other specified fracture of fibula and go into post-coordination options. So I know I don't have one of the upper end or multiple, so I'm just going to pick other specified fracture of the fibula. Again, we know it's bilateral. We know it was a metaphyseal, so I'm going to select that bucket handle or corner fracture again. We know it was closed, so I'm going to select that. Again, I don't know the joint involvement, and I don't know the specific anatomy here to make sure that I'm selecting the right piece, so I'm going to skip those, but I am going to associate this code with my physical maltreatment. And again, we have our code cluster built here at the top. I'm going to capture that code and select it. So now we've coded all the injuries on our infant for vignette number 1.
I know that kind of skipped just a little bit in the screen. It might have been I clicked the chat and that might have accidentally hit that bar to stop the video and we kind of went backwards. I'm sorry on that.
On that, Amber, so it was on my computer. So,
Okay.
but I think you got most of it skipped a tiny bit, right? You got
It
most of
just a little bit on that tibia fracture. But this shows the final codes in ICD-11 for each of those 3 different fractures. You'll see this first one here is the fracture rib. We'll be able to now capture all the details that it was posterior, left, closed, 6th rib, as well as the perpetrator, and that this was confirmed physical maltreatment in that one code cluster for that rib fracture. As you see on the right, you can see the lower end of the tibia, that it's bilateral. It's that bucket handle corner fracture closed, and then the maltreatment confirmed. And same with the fibula. Here we can see that greater detail in those code clusters. One thing I do want to note is I did not code the additional information of the perpetrator in every single code. That may be required, that may not be. You may be able to capture that in one of the codes and leave it at that. That all depends upon the coding guidelines and rules that each country may have when they institute ICD-11 about how detailed you need to get, if you can just put that on one code or if you need to put that on all codes. So I did want to make that note.
Thanks, Amber. This second vignette involves a 5-year-old girl admitted to a children's hospital for leukemia treatment. During her hospitalization, the nursing staff on the ward observe her parents repeatedly arguing loudly and using vulgar language at her bedside. On one occasion, a nurse witnesses the father shouting at the child and the mother, accusing the mother of alienating the child from him and saying that the child would be better off if she didn't always take her mother's side. So psychological maltreatment and neglect have been particularly elusive in documentation by clinicians. Unlike physical abuse, which may leave manifest injuries, psychological maltreatment can be harder to recognize in code. However, ICD-11 does provide some specific categories to capture psychological abuse and exposure to severe parental conflict.
And we'll have a video for the coding for this.
Now we're going to show the coding of vignette number 2, where we have some confirmed psychological abuse to this young girl who's in treatment for her leukemia. While she's in the hospital, the parents are having a lot of conflict, are arguing, accusing her of sticking with her mother. There's a lot of conflict going on between these parents. So we know there's psychological maltreatment. So first I'm going to pick maltreatment. And we get our options below. As you can see, there's like unspecified and other specified maltreatment. There's some personal history of maltreatment. There's the psychological, sexual, and physical maltreatments. So those are used for confirmed, these PJ codes. Then there's other personal history when you know it's a different type of maltreatment that is confirmed from a personal history of physical, sexual, or psychological. And then there's some Q codes that are used for suspected maltreatment. So if you suspect maltreatment during an encounter, these are the codes you would use for whether it is unspecified. We have some specific suspected maltreatment, whether it's physical, sexual, or psychological maltreatment. These would be the codes you would use if you're suspecting some kind of abuse going on. So in this case, we know there's some psychological maltreatment going on. So I'm going to select that code and go into the post-coordination. The first option here is associated with. This is where you would select if the patient has any type of maybe a mood disorder, some kind of behavioral disorder, like an eating disorder or something of that nature caused by the psychological maltreatment. I don't have that detail in this particular scenario, so I'm going to bypass the associated with. Next is activity when injured. And so we know that this patient was being taken care of by a health professional. They were in the hospital. So I'm going to select that. The next option is the place of occurrence. We know this was in the hospital. So I'm going to select medical service area and then select hospital. And then our last option is for the aspects of the assault and maltreatment. And we have perpetrator victim and gender perpetrator options here. So we're going to first select our victim perpetrator relationship. We know this was the father. So we're going to pick father or mother for the perpetrator victim relationship. And then the gender, although some may argue the mother was just as argumentative as the father, but the father seemed to be pushing a little bit more. So we're going to select gender male. So now we have our complete code string or cluster built up here at the top. I'm going to select that, and we will be using this particular code cluster for our patient. Now we're going to show the coding.
So here in this screen, you will see the final ICD-11 code that we've built. Our STEM code is that PJ22 for psychological maltreatment of the child. And our extension codes tell a little bit more about where this maltreatment occurred, that it was in the hospital while they were being taken care of at the hospital, and that the father was the perpetrator of the psychological maltreatment.
Thanks, Amber. So one of the things that we can speculate on or hypothesize is, can ICD-11 help deal with a degree of certainty problem? And I'll explain that. One of the barriers revealed in our research that Andreas has presented earlier is that clinicians are often reluctant to use child maltreatment coding when uncertainty is involved. Many hesitate to document concerns about definitive proof when facing a suspected abuse, and this leads to underreporting. So ICD-11 may be better at addressing this issue by providing codes specifically for suspected maltreatment. Amber had demonstrated that a bit earlier as well, but here are some of those codes in this table. And these allow healthcare professionals to document concerns even when certainty is lacking, or maybe early on in the investigation, the medical investigation, ensuring that potential cases are flagged for further assessment. By using these codes, clinicians can record observations systematically without prematurely concluding abuse has occurred with certainty. This structured approach may improve documentation and facilitate appropriate intervention. So when will ICD-11 be implemented? Well, we don't know for sure in the different countries, but it has been in development for years. Here on this slide, you can read some of the milestones, it being available for member states to implement back in 2022. But full implementation is going to be a gradual process that we can be sure of. WHO acknowledges that transitioning from ICD-10 to ICD-11 is a significant challenge. It's a process that requires substantial technical and workforce adaptation, with thousands of coders and healthcare professionals needing retraining. As the WHO statement quoted here in this slide highlights, while some countries will adopt ICD-11 early, widespread implementation is going to take time. So just to provide you an example of how implementation is planned, at least in an early adopter country where I practice in Sweden. Sweden has plans that are listed here, and again, it's going to be an early adopter of ICD-11 with a phased approach. In the end of this year, 2025, we will have an official Swedish translation, ICD-11 SE, and that will be available. We do have a version that's online in the WHO that is not yet an official, but is a draft, if you will, that is workable, and you can use it to refer to it. From January 1st in 2 years' time, in 2027, it'll be used for the cause of death registers, and in 3 years' time, it will be implemented in health data registers. This is work being supervised by the National Board of Health and Welfare in Sweden, and where they ensure readiness across the healthcare systems. Again, as a reminder, we can see that the full ICD-10 transition took time to implement. There was, for example, a 20-year gap between ICD-10's release and implementation in the early countries in the mid-1990s, 1995 in the United Kingdom and several European countries in the late 1990s, and its adoption in the US in 2015. So an extended timeline might be expected for ICD-11 in some countries. This is a slide just to sort of think about things that have come up in our discussions as we were doing these this project. What we should be thinking ahead about in regards to automation and artificial intelligence in ICD-11 coding. As ICD-11 rolls out, we need to consider this because there are natural language processing and machine learning that are being explored to automate clinical decision support within electronic health records and to enhance coding accuracy by extracting relevant case details in the records, and efforts to reduce variability in coding by suggesting standardized codes based on clinical notes. While these technologies have great potential, they also pose challenges, particularly for coding sensitive cases like child maltreatment. Clinical judgment remains critical, is going to remain critical, and there's a risk of amplifying existing systematic biases if AI tools are not carefully and ethically implemented. So we as clinicians, end users, and coders need to stay ahead of the game in ensuring that monitoring and validation are prioritized so that AI enhances rather than undermines accuracy and fairness in child maltreatment coding. So we invite you to review, again, to access the WHO websites. There's some nice videos and educational materials for implementation. Actually now available in some of it is available in 14 languages in 2025. There's the WHO ICD-11 browser, the ICD-11 coding tool, and ICD-11 tools and training with those additional resources. And I'm posting, you'll get a PDF of these slides to you. Also a link to the Teikendak Project's curriculum contact page in English here, so that you can contact our colleagues at Ulm University if you're interested in the curriculum that can be used and translated into other languages and for implementation. With that, I thank you for joining us so far. We'll go forward. Andreas will take us to the question and answer session.
Yes, I will do so. So just starting with one representing other similar question, Aisha was asking, how can ICD-11 be adapted for use in low resource settings like Somalia to improve child maltreatment data collection? Just let me explain in general, like the ICD-11 is a diagnostic toolkit and not directly connected with procedures and reimbursement. It's the diagnostic toolkit that the WHO provides and is adapted at the national governmental / administrative national administration level for use in each country. So I'm not quite sure how this would work in how this adaptation takes place particularly in Somalia, but in general, like the codes are there for comparable use across the world and are not necessarily hindered or should be applicable in all settings. The question is how and that's what we've seen in the research. The major question is not how to diagnose, but how these diagnoses are reimbursed. I think that's the major challenge. Not Gabby, Amber, do you want to add?
Amber, do you have any comment on how the codes might be used in low-income settings?
I'm not sure if I can add anything to that. I would hope that at some point in time, Somalia, as well as other nations, would adopt the ICD-11 so that their data could also go into other nationwide. It can be compared nationally, internationally, worldwide, with everyone finally using ICD-11 for their work. So I hope we could get to that point throughout the world.
The one thing that we do know is that it is designed to be, as we put it, less clinical modification. When ICD-10 was implemented in the US, you had to build an entire clinical modification. That was not one of the reasons for the long delay in implementing it in the United States?
It was in the United States. We took what was maybe 10 to 15,000 ICD-10 codes and blew that up into a system that is over 80,000 codes in the United States, because we don't use that post coordination. But in the US, they created codes for a left tibia fracture of the shaft that is left, one for right, one. So there's a separate code for each one of those lateralities and additional details in the US. without that post coordination, which would be a better option to provide those details instead of blowing up the code system into hundreds of thousands of codes. And makes it much more usable and comparable between countries, because ours looks very different in the US as compared to other nations.
Thanks. I have a list of quite specific questions or more technical questions that I will read out loud, and then I will go on to the questions that are more about communication and implementing and advocacy on child maltreatment coding. So Mark Hauser is asking, how does the ICD-11 deal with the reality that maltreatment may not show up on the surface of the body, but there may in fact be physiological and epigenetic markers?
Well, as an end user, I think the second case that we used showed how there's some innovation in describing or documenting psychological maltreatment that may not have been as readily available in the ICD-10 system, and you know that basing diagnostic coding on physiologic markers is that would be beyond what the science can support today. But you know, given what I would say, looking to the future, I can't. If there's any specific diagnostics of child maltreatment at some point based on epigenetic changes, well, then we're in a new world. But then that could potentially be linked to be validated and linked to diagnostic coding. But
thanks, Gabby.
The case was an illustration of non-manifest findings, but observations.
We have a lot of questions, and that's maybe don't feel pushed. I'm and to the audience as well. We're trying to respond to as many as possible. If we don't get through with them, we promise to write an answer to the questions if we're not getting through. So the next question is by Julia Quenberger. Will there be a multi-actual classification scheme for mental disorders in children and adolescents according to ICD-11, and an integration of the maltreatment coding in Axis 5, associated abnormal psychosocial situations?
I can kind of take that. I don't know, Julia, if there is something in ICD-11 for associated abnormal psychosocial situations exactly. It's something I'd have to probably research and kind of look through the code set itself. Some of these things can be kind of difficult to find there because you have to make sure you're using the right verbiage in your search tool and that coding tool. But that's something that we can research and look. I know there is a full classification of all the behavioral health disorders, mental disorders, and like that one vignette, could show the association if the child had some kind of maybe a mood or behavioral or mental health disorder. So there is a way to kind of link those together.
Thanks. Or Gabby, do you want to comment?
Well, just briefly, from just having reviewed some of the literature, there's a lot more available on mental health in general. I'm not not an expert in that, and whether there is so there's a lot more work out there that's been published on mental health coding ICD-11. And there's very, very little on child maltreatment. Whether, or in child psychiatry in general, I would venture to say that there's very, very little specifically. So I don't have the answer to that.
And I've seen that too, Gabby, that there is quite a bit online. If you search the internet looking at ICD-11, there's quite a few articles and manuscripts about ICD-11 in behavioral health and mental health diagnostics. So I think if you do search the tools, you might find that. There's also areas in the WHO's website where you can see the proposals for codes that are coming up or being worked to maybe be added to the classification. And there's a lot of work there in the behavioral health section.
Thanks. So next question is, that's an interesting one. Simone Thompson asks, would you only include the perpetrator in the coding for one of the injuries, or each of them? Would it matter?
And in my that vignette number 1, I only added the perpetrator in that gender-patient relationship on the first code. And a lot remains to be is kind of unknowns. Like in the United States, we have a very robust set of coding guidelines and rules. It tells you exactly how you should maybe sequence things and how would you add that on every single code. And a lot of that remains to be seen when each nation implements and if they have specific rules on what level of detail. Do you need that on every single code when one code could maybe tell that piece of the story? It remains to be seen. I wish I had a definitive answer for you on that one.
Then I have another one. Are there codes for physical emotional neglect? And if so, is it recorded separately from maltreatment? I noted, although I might be mistaken, that neglect was not among the codes appearing under maltreatment. And this is a question by Refili Iftimiado. I hope I did not butcher your name completely.
I did pull up the coding tool and type in neglect into my search bar, and there are some codes for like assault by neglect, personal history of neglect that I could pull up very easily, unintentional neglect. So that was another one. Then there's, for suspected neglect or abandonment, there's a Q code for that as well. So there are some different neglect options there. I need to kind of dig in a little bit more to see exactly what are all the various options for neglect. I know there are some codes for that in ICD-11, and we could maybe search for those and outline those a little bit better for you, if that would be okay.
Would you say, Amber, that they're compared to ICD-10, that there's more nuance and detail in ICD-11 on neglect?
I would agree that there would be in ICD-11 for neglect, that there's even neglect with undetermined intent out here that includes post-coordination options for that. Just kind of tells me that there is more specific nuances there in ICD-11 for that option.
In general, I would add, like, it's much more. The challenge is there's much more detail and options of coding available in ICD-11, but we still have, this is a sneak peek, and it's not yet nobody. Well, maybe there are very few people who might actually using it, but it's not. We have very few country versions that are full in use, and we have to see how it establishes itself worldwide, and if these options of post coordination, the different combinations are actually used, and which one will be irregularly used, etc. So this is just be reminded of the nature of that we are in a transfer or in a kind of trying to do a prognosis on how it might look like. Okay, I'm moving on to yet another question that is by Mark Hauser. The psychological maltreatment vignette seems highly subjective and potentially misleading. The vignette had one instance, and my sense is that under stressful situation of a child in a hospital, many parents might say things that they regret, but it wouldn't count as psychological maltreatment. Reporting here seems to demand further evidence and development. Is this part of the coding?
I can try and respond to that. Thank you for that take on it. This is a case vignette that was developed by our colleagues in Germany, pediatric colleagues who wanted to illustrate a case of for our curriculum of psychological maltreatment. And you know, whether this is the correct coding, we can't say at this point, but I certainly would agree with the teaching points that were built into the case scenario, that it should trigger you know, an intervention, and then certainly in my setting in Sweden, where we have mandatory reporting for health professionals to Child Protective Services, it would certainly cross the threshold for a mandatory reporting. So yeah, it would be definitely supported, and whether or not you diagnose it as child maltreatment, I think it remains to be seen how it's going to look like in the actual practice. But it certainly seems like a reasonable interpretation to me, and in the coding cluster, in what we know today about ICD-11.
And I might want to add, it's also the question of from an epidemiological perspective, if you focus on the act itself or the need, or more on severity and the need for intervention on how you document. But at least from the German context that the colleagues have developed it, I would concur with Gabby that we don't have mandatory reporting in Germany, but it would also cross the threshold for the need of reporting. Okay, next question is, I'm trying to double check if we have most of the more technical question. So let's take a few on the communication and how it links with child maltreatment coding in other contexts. So Sarika Devan asks, how does the coding of child maltreatment in the ICD-11 link with other international classifications on violence, for example, ICCS and the ICWAC, UNICEF's? So the UNICEF's is what I've added, UNICEF's ICWAC, the International Classification of Violence Against Children.
I think you're best positioned to respond
yeah.
on that.
I just had to take a short breath. Yeah. So that's one of the bigger challenges, that there are several classification schemes on child maltreatment. I've been working with the it just started the International Classification of Violence Against Children, and will be, the purposes are somewhat different. So the WHO's classification scheme is developed for use in healthcare and to connect it to diagnosis. That UNICEF's ICWAC has a different approach, has more of a like also the prevalence connected to the idea of prevalence surveys on having a comparability of approaches, but it's not as the ICWAC or ICWAC is more of a nosology, like so general. It's not a fine-grained coding system of different diagnoses, but an approach to how different acts, incidents, omissions, under which category they should be seen. Is this considered child neglect, child maltreatment? So it doesn't go fine grained. It might connect, but the use of the two systems, ICWAC and WHO ICD-11, is quite different, and they are at least the child maltreatment subtypes can be converge, I would say, can converge with ICWAC and WHO's ICD-11, but it's not like, yeah, I'm going in circles right now, but it's not like the aims and goals of the tools are quite different.
Do you want to, Andreas, give a shout out to the work that we produced in the Eurocan network that you and say that we're also I would say that the ICWAC is a novel system, but it's not validated, and it wasn't. It was put together by expert panel, but not a consensus. And if you want to describe our work and shout out about our paper that was just published.
I will link the paper in that was just published. You have introduced the shout out. That's the consensus-based approach to, but also, as you said, ICWAC has just started. I'm not sure, like you have realized, this is a debate or discourse that we could do yet another webinar on all those differences. So if you're interested, if you're more interested in a more lengthy response to how these approaches converge or not, happy to respond to. So I'll go with the next questions. How would you suggest training community? So this is Khadija Al-Sharif, who asked, how would you suggest training community health workers, for example, in the ICD-11, and also potentially relating it to, well, that I'm not familiar with the acronym MHGAP. So, but the first part of the question, how would you suggest training community health workers? That is definitely a part we can try to respond to.
I would say that ICD-11 on the WHO's website, the WHO website, they do have a lot of training tools for how to use the ICD-11 system as it is straight out of the box from WHO. So that is one way, but I would recommend don't start training too early if it's not going to be implemented in your country for many, many years. You don't want to train and then not use it for a long time before you get that opportunity to to implement. But the WHO currently right now has some very good training tools to kind of familiarize yourself with the system. I don't know if anybody else would like to share anything else.
Thanks, Amber. I think we are good to have two more questions. So Nina Livingston is asking, my observation is that coding specificity has been degraded as hospital systems in the US have shifted the burden of coding from coders to busy clinicians selecting codes in the electronic medical record. I wonder what thoughts you have about how clinicians and hospital systems can be incentivized to use ICD-11 to its full potential.
Well, as a coder myself for many, many years, I advocate for coders coding, clinicians working with patients, and just documenting. That would be my goal. And I hope, as automation comes into play, natural language processing, maybe extracting bits of data from the documentation of a physician or a provider, that that piece will be back in the coder's hands to make sure that those codes are accurate and correct. The future of technology will really change the world of coding here within the next 10 years, I have no doubt. So that kind of remains to be seen, but I'm a big advocate of coders coding and physicians doing their work, clinicians doing their work, and not picking codes. They're not coders, and they shouldn't be.
Maybe this connects to a student question. Amira Yahya asks, as a public health student, what advice would you give us students? What should be our main focus right now to hopefully be of use in the future and bring a change? So I know it's a bit general, but maybe what would be our recommendations to implement it also for students?
Well, again, the educational materials are really quite comprehensive. The stuff that we link to on the WHO website. So I think that's one way. But also, if you're engaging with your national entities that are implementing, I know that here in Sweden, our project, the Taikendak project, has engaged with the National Board of Health and Welfare, who were very pleased to see that we were doing some, doing some sneak peek work. We were ahead of the game, looking at how this might be a window of opportunity. So while we might not be able to influence the content, we may be able to influence how we gain more knowledge in research through how the ICD-11 is implemented, and again admonish us to be ahead of the game and take a look at these automation elements that are coming in, and it's going to happen very rapidly. So if you're a student in public health and that's an area of interest, please, it's an area that's rapidly developing, and we need your help in putting the and staying ahead of the game and making sure that it's ethical and as bias-free systems as possible.
I have another, particularly for some of these folks in countries that are maybe smaller and it's more difficult to get change happen there. And you're wanting to stay kind of on top of things, look at the International Federation for Health Information Management Associations, the IFHIMA.org. They are an international federation for health information management. They have a lot of webinars and things that go on about ICD-11 and as it's being implemented around the world. And they're sure to have more content regarding ICD-11 in the future. So that's one place where people can stay kind of in the know. And then I would recommend definitely the WHO's website for anything regarding ICD-11 as it's being implemented.
Thanks, Amber. Our time is almost up. So, Gabby, do you want to wrap up?
Well, the three of us can kind of wrap up, thanking everyone for joining us today. I hope it's been helpful for you. And thanks to ISCAN. Jane Estes is in the background helping us produce this. And your feedback matters. Please take a few minutes to complete the Zoom survey so that we can, at ISCAN, make these sessions more resonant for you. And then again, you're going to get, we'll be sending out the slides in PDF, and the full recording will be available at ISCAN website, but also eventually at on YouTube. So feel free to disseminate.
And we want to try, as promised, we have 7 questions unanswered, and we will ask Jane if we get them out of the Zoom system, and we'll try to respond to you. Thanks for having been here. It was a pleasure. A lot of questions, and I'm hoping you stay on top in improving child maltreatment coding in the future with us. Goodbye, good night, good working day, if wherever time zone you are in. Hope to see you in another webinar of ISPACAN. Bye-bye.
Bye-bye.